is a celebration that we share in patient blood management with also the bloodless care practitioners. And we have a really fascinating and shared history, but I was so surprised when I was reading and doing research for this podcast. There's some scandal and intrigue in there. But the takeaway message really is that of passionate physicians who were willing to persevere under trial. And it's led to the progress that we have in medicine today.
Yes, absolutely. And, really just, it makes so much sense when you understand it. And who better to have this conversation with than Dr. Nathaniel Usoro? Hi, Dr. Usoro.
Hi, Marianne.
So,
Hi, Sarah.
hello.
Happy to be
Hi,
with you.
Dr. Usoro.
Dr. Usoro, why is that? Why is May such an important month for bloodless medicine and surgery?
So May is an important month for us in bloodless medicine and surgery because of someone who is widely regarded as the father of bloodless surgery. If you look in the medical literature, you will find that Dr. Denton Cooley is often referred to as the father of bloodless surgery. That is modern bloodless surgery. And it was in the month of May, on the 16th of May, 1962, that's 61 years ago, that was when he carried out his very first bloodless open heart surgery. Now, it used to be thought, well, you could do bloodless surgery on minor cases. You're doing a hernia, lipoma, or some minor case, but you can never do it in a case like open heart surgery, where they use like 20, 30 units of blood on a patient. But as we might have noted, some patients decline blood transfusion. And Dr. Cooley took up the challenge to carry out open heart surgery on patients who decline blood transfusion. And the very first one he did was, as I mentioned, on May 16, 1962, on a Jehovah's Witness. It was successful. And beyond that, he went on to publish 500 cases in about 1970, early 1970s. The surprising thing was that it wasn't just that he managed to do those cases, but rather the outcomes were comparable or better than those patients who were transfused. And thereafter, he went on and did hundreds more than 1,000 bloodless cases, and he had very good outcomes. So we show regard, we remember his work in the month of May. The World Bloodless Surgery Day is May 16. And the whole month we have various bloodless programs, setting up meetings and talks to raise awareness about bloodless medicine and surgery. And our society, the Bloodless Medicine and Surgery Society, and SABM, to which I also belong. So we particularly mark this month and a week of it from May 15 to May 20, which incorporates the World Bloodless Surgery Day on the 16th.
That's, Dr. Cooley is well known to people that work in the OR, in the surgical field. He was really a pioneer in his field, and he's well known. So that says a lot that he noted that the outcomes were better with bloodless surgery and just kind of went with it. And boy, really was very helpful for bloodless medicine. He did so much, just unbelievable. What a pioneer.
When I was preparing for this discussion, one of our listeners, John, if you're listening, thank you so much. He recommended that I read the book called No Man's Blood. And it's currently out of print, but he thought that I could find it, and I did. And it was a story of another doctor as well, who began his surgical practice in the 70s. And his name was Dr. Ron Lappin. And Dr. Lappin was a young surgeon. He was very confident, and he wanted to be the best And there was new technology coming out at that time regarding the electrocautery knife, but it wasn't really being adopted very well among the medical surgeons. And he really felt like this would reduce transfusions and make him the best. Um, and he got the opportunity when he was faced with a patient who had miscarried and now was hemorrhaging because her fallopian tube had ruptured from the miscarriage. And other surgeons were turning people away and saying, if you don't take blood, you're going to go home to die. And I was reminded of our discussion with Dr. Shander. He said that was happening in the early days of medicine. I just have never seen that. So the stories in that book and what Ron Lappin did, it gave him the opportunity to wield the electrocautery knife. I think he was a little bit excited about that. But he was, I can't let this young woman die. So he took her into surgery, and that was his first bloodless medicine surgery. And he became he created techniques and he practiced, like you, pretty much exclusively bloodless surgery. And he became well known for it. Physicians didn't like that they were saying surgeries can't be done, and he was taking those surgeries. So there was a lot of scandal involved, and other physicians got the legal state of California involved, saying that he wasn't practicing to what was standard of care. And for many years, he fought those legal battles. But interestingly enough, on May 16th, 1986, is the date that California dropped all legal charges against him because they found that they were unfounded and there was no evidence of bad practice. And then fast forward a few years, he died early at the age of 53, kind of unexpectedly. But would you like to guess the date that he died in
No,
1995?
no.
It shouldn't be.
Is it May 16th?
He died on May
Oh my
16th,
goodness.
1995. Yeah, I didn't know it. I was blown away by that. But again, another great surgeon who really saw the standard of care was better, but great outcomes, and traveled the world talking about bloodless medicine.
So, Dr. Usoro, when we talk about bloodless medicine, we're talking about no blood, right? So I think for some of our listeners here, they're trying to understand we're talking about no blood. Like, isn't that a little extreme? Is it safe? Can you talk to us about that and why you do this?
First of all, let me thank you, Sarah, for the story you just told. I'm hearing it for the first time. I'll have to try and get the book and read it. Talking about no blood, is it safe? Well, medical scientific evidence shows that it is safer than transfusion. And there are many reasons for that. So, transfusion is inherently unsafe. And a lot of times we're thinking in terms of transfusion, transmissible infections, HIV, hepatitis B, and so on. Yes, those are hazards of blood transfusion, infectious hazards. In medicine, we're used to hazardous situations, and we sort of calculate the risk benefit ratio. And if the benefit is more, then we can take the risk. So I'm not dwelling on those infectious hazards or risks because maybe we could take them if the situation warrants. But there is more to it than that. Um, there is something that makes blood transfusion inherently unsafe, and that is immunomodulation. So we usually just test ABO blood group and we check for compatibility and RH. That's it. But there are lots of other antigens in the blood. And remember that blood transfusion is actually a tissue transplant. So it's similar to transplanting a kidney, for instance. And how would you look at a surgeon that transplants a kidney based on ABO and RH compatibility only? That wouldn't be sensible to do. So they're going to check for a lot of things, and among which are the HLA antigens. But what's the meaning of HLA? Human leukocyte antigen. So then, does it make sense to check for HLA with kidney and then pour everything in the blood into someone else without checking? So evidently, we could say like 100% of our patients would have some immunomodulation due to transfusion, regardless of whether they were AB or RH compatible. And that is thought to be a cause of the greatest cause of death due to transfusion. There are early problems, but there are also late problems that take years to manifest, and all kinds of issues with increased incidence of infection, be it wound infection, cancer, recurrence, and so on and so forth. And the percentages are not like increased like 10%, 20%. You're talking about increase like 1,000%. That sounds very strange indeed, but it's true. So
Wow.
there have been lots of publications on this to show that virtually all patients suffer immunomodulation. Then you think also of storage lesions, because we don't just, at least in my setting, we don't just take blood from the donor and put it in the patient. We store the blood, and the blood degrades on storage. So that's what we call storage lesions. And with that degradation, it ends up not doing what we wanted it to do, like improve tissue oxygenation. It doesn't.
Yeah, you gave us a lot of research to look at before to prepare for this episode. And I was taken back by the article. I'm going to pull it up here. The impact of red blood cell transfusion on peripheral capillary oxygen saturation and partial pressure of arterial oxygen. That's a lot to say. But the main proponents to this study was, we all know that hemoglobin is the protein that carries oxygen to our vital organs, and that hemoglobin rides around on the transport of red blood cells. So these patients had a lower hemoglobin. And so with that, you would think a lower ability to carry oxygen. So they were transfused red blood cells to correct their hemoglobin. The number was corrected. And yet, after transfusion, their need for oxygen support medically went up. Why does that occur? What's going on at that capillary level that they now need more oxygen, even though we've corrected the amount of hemoglobin that's in their body?
Right. So that has to do with the storage lesions that I mentioned. So the red cells on storage become fatter and lose shape. The normal shape is biconcave disc, but then they become fat and lose that biconcave shape. They become what is known as spherocytes, and they also develop projections on the surface of the cell. Those are echinocytes, and some are both fat and with projections. So those are spheroechinocytes. What happens is that at the capillary level, when the red cells get there, they squeeze past one by one. And that biconcave shape is required for the red cells to squeeze past at the point of delivery of the oxygen, which is at the tissue, capillary level. They can run up and down in the big vessels, aorta, and big arteries, and so on. But when they get to the tissue, they have to go to the capillaries, like the small side streets. and then they have to go one by one, and they have to move like sideways with the biconcave shape. So what happens when they change shape due to storage and they become fat and develop projections? They cannot squeeze through those narrow capillaries. And so they just go there and block the capillaries. And obviously, there's going to be increased hypoxia. But that is just one part of the story. It's very complex. There are other aspects. For instance, storage leads to depletion of nitric oxide, which even when the red cells are biconcave in shape, they still need nitric oxide to open up the capillaries a little bit so that they can squeeze past. So now there's no nitric oxide, and then the cells are also fat and misshapen. So that's a double whammy, a double trouble. Okay, now also the red cells need to offload the oxygen when they get to the tissue from the hemoglobin. And this is an active process. It requires what is known as 2,3-DPG. So when blood is stored, there's a depletion again in the 2,3-DPG. Nitric oxide depletion takes hours, within hours, but 2,3-DPG gradually depletes so that by the time it's up to 2 weeks, there's like 0 2,3-DPG. And how long do we store blood for? We might store blood for up to 6 weeks, 5, 6 weeks. And when we order blood, which one comes to us? It is the one that is about to expire, usually, except we particularly request fresh blood, which it may be 1 or 2 weeks old. So the thing is that the hemoglobin may get, if it manages to get to the tissue level, is unable to offload the oxygen because there's no 2,3-DPG because it's been depleted due to storage. And lots of other enzymes and various agents that are needed, like ATP, they are depleted, and others. So that it compounds the problem and causes hypoxia when a patient is transfused. But what if you're doing bloodless? In that case, you're not compounding the hypoxia, but you're helping. How are you helping? You're going to be using for volume replacement because that's the urgent problem. If somebody's losing blood, for instance, it's volume replacement that is the urgent thing. So you're going to use crystalloids and colloids. And when you do that, you actually bring down the viscosity of the blood. And that alone can greatly help with the cardiac output and help to improve the oxygen, actually. And of course, we administer oxygen in bloodless surgery to the patient. So the oxygen therapy plus the fact that we are giving fluids that bring down viscosity. And on top of that, we're going to try to build up the blood if there's been blood loss. So we're going to give IV iron and erythropoietin. Erythropoietin, apart from increasing the red cell mass, also improves tissue oxygenation. It has so many other things it does that helps. Remember, it's a banned drug in sports. So we actually use it to enhance our patient's performance and recovery.
Wow. So you're saying that we should be looking at and treating the problems and not just responding to a number.
If we're going to respond to a number, we should respond rationally. We should, for instance, we can say, oh yeah, this is a low hemoglobin. So we respond rationally by giving intravenous iron and erythropoietin. But we're not going to respond by giving something that is going to cause hypoxia and will make the patient stay longer in hospital, go to the ICU and so on, which is blood transfusion.
Makes a lot of sense.
Okay. What about the hemorrhaging patient and the hemoglobin is already dangerously low? We're talking the 2s and the 3s. Is it safe for that patient?
So in my setting, a hemorrhaging patient is in grave danger if they are transfused. And I think it's not only in my setting. Um, why are they in grave danger? Blood transfusion increases hemorrhage. You can find that in several studies. Check up on studies on upper GI bleeding and use of blood products. It's almost universal. All of them show that blood products, red cells, plasma, any blood product tends to worsen the outcome. It leads to further hemorrhage, more morbidity, and death. So in my setting, it's because we use mostly whole blood. It's easy to understand why. To start with, when we're transfusing, the blood comes with anticoagulants, and it's impossible to remove the anticoagulant before giving it to the patient. And patient is bleeding, so obviously the patient is going to bleed more. And the more we give, the more bleeding. So it's sort of dose dependent. Okay, now also we've stored the blood. And how long do platelets last in stored blood? 24 hours.
Mm-hmm.
So, of course, we're not going to get blood of 24 hours age. We're talking about the blood of 1 week is talk of 3 weeks and more. And there are no platelets. There's zero platelets in that blood. So there's going to be dilutional coagulopathy. The more of it that we give to a bleeding patient, the more we're even diluting the patient's own platelets. So that compounds matters a whole lot. And if we're giving 2, 3, 4, 5 units of blood because patient is still bleeding and we need more and we keep asking for more, remember that we only did ABO and RH, and we only did it between the patient and a specific donor. But each of those units comes from a different donor, and everything is coming into one person who is actively bleeding. So the chances are that we can actually induce disseminated intravascular coagulation immunologically.
Mm.
And a patient ends up bleeding to death. It's been happening in my setting, especially obstetric patients who are
That's
continuously those who are well off and have access to a lot of blood available. They get transfused, and sometimes they die on table. Whereas the poor ones who don't have money to get blood uh, actually often make it. They may bleed a lot, but they go home.
that is some compelling arguments, I must say. And now I understand the chapter in the book that you wrote where you talked about instead of massive transfusion protocol, we need a massive hemorrhage protocol and shift more into that direction about managing the hemorrhage. So very
Yeah,
interesting.
because up till this moment, the when you talk about massive transfusion protocol, the ratios are still contentious. I mean, the ratio of the red cells to the plasma to the platelet, those are contentious. Nobody can really say this is the best. I live and work in a low-income country, and generally, low-income countries, according to the World Health Organization, the WHO fact sheet, 2011, uh, it says that 47% of blood donations in low-income countries is tested in labs without quality control. Um, Maybe I'm jumping the gun a bit because you're talking about you've got the blood and you're testing it in a lab that doesn't have good quality control. Let's even start from donation because there are some authors that published in 2020 an article, Blood Transfusion Safety in Low Resource Countries. This was Block and colleagues in Annals of Internal Medicine. So I want to read something from their article. It says, the underlying different deficiencies that contribute to suboptimal transfusion practices defy geography and span the complete vein to vein continuum from collection through infectious disease testing, quality oversight, and transfusion itself. So these authors are saying that the problem spans all the way from collection. What the WHO mentioned had to do with testing, but through testing to even quality oversight and transfusion itself. Why do they say that? Because uh, first of all, most of the blood in our setting is gotten from paid donors, and when you have paid donors, now that's a big problem. So you're going to have blood that is inherently unsafe in terms of transfusion transmissible infections. There's going to be a lot of that. And so 2021, the Guardian newspaper, quoting WHO sources and other respected medical sources, actually said that 95% of donor blood in my country is unsafe. So they were quoting experts on the subject. That's a big number. So,
95%. Wow.
So you have from the issue of the donors, then you have the problem that a lot of the transfusion transmissible infections are endemic in my setting, and many of them we cannot even test for. Okay, so we test for four, which the WHO says we should, in the good labs. There's HIV, hepatitis B and C, and syphilis. That's it. But there are many other things that are transfusion transmissible, from viruses. I mean, Epstein-Barr. I can't even begin to name them. Protozoa, even the simple malaria, which is endemic in my setting, herpes, and so on and so forth. The herpes being a virus, of course. And you don't even talk about the newer, we won't even go there, newer pathogens, which nobody's able to test for. So a lot of these things are endemic in my setting. And there's simply no way of testing for all these things. Otherwise, a unit of blood is going to cost more than a kidney or a liver. And I mean, this is a low income setting. So you add that problem to what the WHO is saying, that much of the blood is, almost 50% of the blood is tested in labs with poor quality control. So they're not even testing enough of the pathogens, and yet the quality of the testing is also low. And oversight, the transfusion itself, it's a problem. How do you store the blood? I mean, our setting is almost synonymous with power outage. And if the power is always going off and the blood is in the fridge, you can't put blood in the freezer. And how do you cope with that? That is tough.
Let me ask you this. If you were practicing in the United States, where there was more safety measures in place, better refrigeration, better testing, all of the resources available, would you choose bloodless medicine?
So those resources could reduce, they would not eliminate, they would reduce the hazards, but they do nothing at all to the adverse outcomes in terms of immunomodulation, for instance, because you're not going to do in the US, you would not do HLA testing before your blood transfusion. Otherwise, it would become very expensive. So, and you're still going to have storage lesions if you store blood. You cannot, if you only use fresh blood, then the blood banks will close down. You cannot continuously issue blood that just got donated now. So I think I would do what many great surgeons in the US do, and that is bloodless for virtually all patients.
Yeah, it is a growing practice. I think more and more surgeons are moving towards a more bloodless approach.
Yeah, and we hope to get the word out about this because it's better for the patient. So many good outcomes Sounds like you do a little bit of preventative medicine, do some thinking about it, and think about exactly what the issue is that you're trying to treat. And it seems to make so much sense.
Indeed, it
Good point.
requires attention to medical ethics because the bloodless medicine addresses all aspects of medical ethics, from patient
Mm-hmm.
autonomy, respect for patient autonomy. You're talking about non-maleficence, that is not harming the patient. Beneficence, it should be beneficial to the patient. You're talking about justice. So it's not just those who decline. You have to be, everybody
Hmm.
is entitled to a good outcome. And
You've really given us a lot to consider. And I know that your society has a week of activity. And if people want to learn more about bloodless medicine, can you tell us a little bit about your upcoming
oh
conference?
yes, that will be next month, May 15th to 20th. That's Monday, May 15th to Saturday, May 20th. So there are going to be some great speakers, renowned speakers talking on various subjects. But the theme for the week is bloodless medicine, the nuts and bolts. So this time we're going to concentrate on practical issues of bloodless medicine. The pillars of bloodless medicine are similar to the pillars of patient blood management. Just that we added, or let me not say we added, there's one more to it. So we have to raise the hematocrit, we have to minimize blood loss, and we have to optimize tissue oxygenation. And we need
Yeah.
to help the patient's tolerance of anemia. So all of those are pillars of patient blood management, except for optimizing tissue oxygenation, which I think is subsumed in one of the other pillars. Uh, so uh, this time we're going to look at each of those pillars and see how we can practically apply the techniques under each pillar.
I could tell by your enthusiasm that you're really excited and looking forward to this. And I've listened in on the week before the presentation, and it's always just excellent. And we'll provide the link to the Bloodless Medicine and Surgery website in our description, and we'll provide our listeners with links to the YouTube channel too. This is going to be, I think this year is going to be the best. I'm always looking
Thank you,
forward to it.
Marianne. So the link would be available by April 30th.
Any special message to our listeners that you would like to, as a takeaway?
Oh, yeah. So for my colleagues, I would say many of my colleagues are actually well versed in bloodless medicine and surgery, and those who are not are trying to learn more now because we, like in the meetings, we have lots of attendance. Even in SABM, lots of people are showing up. So we have to continue because it's an evolving discipline, and more advancements are being made. For those who are not into it, we should learn. We should learn. It is actually not. It's actually common sense. Much of it is not very taxing to learn. We should start practicing it. We can start with patients who decline if we've never done it before. Not that we're using them as guinea pigs, but at least they already have said we don't want a blood transfusion and we're going to give them the best. So we can start from there. We will not, let us not look at them as patients who are tying our hands behind our back. No, let's look at them as patients who are giving us a chance to improve ourselves and who are going to come out better. They're going to improve our own records in terms of outcomes.
Mm-hmm.
So let us put in our own
Yeah.
best in terms of studying the subject and providing what the patient actually needs. Let us not hesitate to call in others who who might be knowledgeable. If we're working in a center where there is a bloodless medicine and surgery group like in mine, or a bloodless medicine and surgery program, let us involve them So, but for the patient,
Mm.
you can seek help from a bloodless program, and from a physician or a surgeon who is knowledgeable in bloodless procedures. It's not it's not a religious subject. It is a scientific subject, and is also an ethical subject, an issue of medical ethics.
Very good. Thank you for joining us today. I've thoroughly enjoyed our
Thank you,
visit.
Sarah. Thank you, Marianne.
We hope you enjoyed this conversation and found some takeaway or new thought that improves your health. We would love to hear from you. Feel free to reach out to us on our website if you'd like to see what we're up to. Our website is letstalkpbm.com. If you enjoy our conversations, please like and subscribe wherever you listen to podcasts and on our YouTube channel.
Special thanks to our guest and our producer, Delaney Coronado, and the entire production team for all of their expertise in content creation, technical abilities, and dedication to our message. We appreciate the experts who drive this medical movement forward, and our affiliate partnerships who support the work that we are doing. Until next time, stay connected to your blood health.